No. Welcome, everyone. We're just going to give it a minute or two just to let everyone join, but thank you for joining us this evening. Welcome, everyone. Thanks so much for joining us this evening. And we're just going to give it just another minute just to make sure that everyone can join. Thanks for joining us this evening. We're just waiting for a few others. Okay, I'm going to kick it off. So my name is Aoife Bradson, and I am the Marketing and Communications Manager for Sims IVF. So a little bit about Sims. So we have 3 full clinics in Ireland. So we have one in Cork, where our speaker this evening, Dr. Moses, is the clinical director. We also have 2 clinics in Dublin. So we have one in South Dublin in Clonskeagh and one in North Dublin in Swords. And we also have a satellite clinic in Carlow, which is just in the Midlands, that will kind of look after you if you needed bloods and scans during treatment. And we're also part of Virtus Health, which is one of the global providers of fertility treatment. And so we have a great network of support behind us as well. So I think we have most people joined now. So I'm going to hand it over to Dr. Moses, and he's so I'll hand it over to Dr. Moses.
Thank you very much, Aoife. Hi, everyone. My name is Dr. Moses Batwala, and thank you, Aoife, for arranging this. And I'm the clinical director down in Cork. I joined Sims in April of this year, and I've been enjoying settling down in Cork and being treated very, very well down here in Cork, and enjoying a very warm Irish welcome. So I'm going to be talking today about IVF treatment for women with low ovarian reserve, and I've got a bit of a presentation which I'm going to be sharing, and I'm hopefully I'll be able to do my talk within about 45 minutes, and after I've completed it, and if there's time, I will try and take some questions from you. So welcome to Sims, and I'll hopefully I'm okay with this IT. I'm really crap at IT, but hopefully this will go okay very well. So that's myself. I'm Dr. Moses Batwala, and as I mentioned, I'm the clinical director of Sims. A little bit of background about myself, just so that you, some of you will understand the kind of background I have in infertility, the kind of training I've had, and exposure, which has shaped the kind of doctor that I am. I graduated from Leeds University in Yorkshire, up in Northern England in 2001. I graduated with a distinction in biochemistry and medicine. And then I got my MRCOG qualifications. That made me a member of the Royal College of Obstetricians and Gynecologists in the UK in 2009. It was shortly after 2009 that I began my subspecialty training in fertility, and I became a consultant obstetrician and gynecologist in 2013 in Sheffield, which is also very close to Leeds, where I studied. Immediately after I graduated, I became a senior research fellow at the University of Oxford, and I began my master's in looking at the quality of life of patients going through fertility treatment. And that was from 2014 until 2016. I then became the lead consultant for ABC IVF and Create Fertility, which were both in London. They're actually sister organizations. And this was from 2016 to 2019. And very importantly, in the context of this talk, Create Fertility is the home of mild and natural IVF in the UK. They Create Fertility look after almost 60% of all women classified as having low ovarian reserve in the UK, and they do quite a lot of cycles. one of the clinics which I worked in, which was their biggest clinic, we did about 2,500 cycles a year. I then became a medical director for another clinic called IVF London, which I was, and I was there from roughly May 2019 until May 2021. And at that point, that's when I joined SIMS as a clinical director down in Cork. So I believe the best thing is to, first of all, define what we're talking about and then go into the nitty-gritty of low ovarian reserve. And we're talking about this in terms of infertility. And what is infertility? According to the WHO, infertility is described as a couple having difficulty getting pregnant after 12 months of regular unprotected intercourse. And the World Health Organization believes that this affects roughly 1 in 7 couples. And today, what we're going to talk about is a subsect within this, these couples, because there are many reasons why couples can may be infertile or have difficulty conceiving. It could be that the woman has blocked tubes. It could be that she's not ovulating. It could be because the male partner has a low sperm count or no sperm at all. There are quite a number of reasons why a couple may not get pregnant. And one of the reasons could be because of egg quality. And today we're going to talk about egg quality, ovarian reserve, and strategies of treating couples who have a low ovarian reserve, and in the context of IVF. So what is egg quality? You hear lots and lots of people talk about egg quality, egg quality, egg quality, and it's a kind of almost an amorphous term in the fertility world. But the simplest term I can use to explain what egg quality is, it is the capacity of a single egg to be fertilized by a healthy sperm and become a healthy embryo, which can implant into a healthy uterus and result in a healthy baby. So that is what we call a good quality egg, an egg that's able to be fertilized, become an embryo, implant into your uterus, and result in a healthy baby. Okay. And what about ovarian reserve? Because we hear a lot of, there are lots of people who talk about low ovarian reserve and egg quality, almost as if one is a substitute for the other. But ovarian reserve is literally just means, it's a term used to determine the quantity, and that's not quality, but the quantity, the number of eggs that a woman has inside her ovaries. Okay. And the two terms, egg quality and low ovarian reserve, I didn't put them, and low ovarian reserve, they're not egg quality and ovarian, they're not the same, and neither are they related. They're actually two completely separate issues. You can have good egg quality and a low ovarian reserve, and you can also have very high ovarian reserve, lots of eggs, but poor egg quality. Okay, the two do not necessarily go hand in hand. And this is what not only, and I would say, not only do patients get confused, but even clinicians themselves. And I've had almost 15 years experience in infertility, and I've noticed that just not only patients, but also sometimes clinicians themselves, who sometimes think that two go hand in hand when actually they're not. They're really independent factors. And to really strike home the point, egg quality refers to the likelihood of an egg getting fertilized, resulting in a healthy baby. And this is mainly defined by one thing, and that is really the age of a woman. The age of a woman is literally what determines the quality of her eggs. Okay. Whereas ovarian reserve, in the context of IVF, refers to the ease of stimulation with IVF drugs to collect a good number of eggs. And what we'd refer to as a good number of eggs is anywhere between 8 to 16 eggs is what we call a good number of eggs. And your ability to easily get this number of eggs is determined by your ovarian reserve. And it has nothing to do with a woman's age, okay? And this is determined by a woman's genetics, i.e. how many eggs she's carrying from the time she was born. And sometimes, rarely, or in a few cases, maybe about 5 to 10%, it is affected by environmental factors such as surgery, if a woman has had surgery in her ovaries, which has taken away a lot of ovarian tissue, that has taken away some of her ovarian reserve, or conditions such as endometriosis, which can damage ovarian tissue and destroy the ovarian reserve. Okay. And it's not fair to just talk about ovarian reserve, without taking into context the man, because for a woman to make a baby, she needs a sperm to fertilize her eggs. And we don't talk a lot about men's age. We do slightly, but we don't talk enough. And what is the reason? And the reason for this is men's of sperm reserve and quality decline only very slightly with age, not as much as a woman. And I'll come to explain to you why. And that's because men produce brand new sperm literally every 2 to 3 months from the time they hit puberty in their early teens until the day they die. They're producing brand new sperm every 2 to 3 months. And literally for that reason, that's why I always use my common example of the Rolling Stones, and how like almost every year one member of the Rolling Stones will appear on Hello Magazine with a new child, and most of the Rolling Stones are in their 70s, and the reason for this is most of the time they have a different partner who is a younger lady, and that's why they and although when they because the men are still able to produce sperm, their sperm are able to fertilize the eggs of their younger partners and therefore have a child. Okay, and for a man, they're on average producing 15 to 20 million sperm per mil in every ejaculate, and 4% of these sperms are chromosomally normal. And that's roughly about 600 to 800,000 sperm capable of fertilizing an egg in each ejaculate of the average man. And that's why you have men who can father children into their 70s and 80s. Okay, and this is just a small diagram of a depiction of sperm. And right there on the extreme left is what we call a normal sperm, which form about 4% of the sperm that men produce. And on this other side are abnormal sperm, which wouldn't fertilize a sperm, or if they were to fertilize a sperm, it would result in an abnormal embryo. However, 4% of sperm are formed by, and these normally are the healthier ones, and they swim faster than these other sperm, and normally get to the eggs first and fertilize them before these ones do. And because men are producing a large number of that, they're able to fertilize eggs well into their 70s. So what is different with a woman? Women, unlike men who are constantly producing a brand new number of sperm every 2 to 3 months, women are born with all their eggs. And actually, a woman's eggs are formed when a woman is still about 16 weeks pregnant in her mother's womb. And that's, so when I'm assuming majority of the people today on this webinar are female. When you were 16 weeks pregnant in your mother's womb, that is when you had all your the highest number of eggs you ever had, and that was roughly 7 million eggs. And from that point, that number of eggs start declining. Okay, they're never renewed. That was the highest number, and from that time on, they're declining. And by the time you were born, on average, when a female is born, she's down to about 2 million eggs at birth. And the eggs are still dying, just naturally, like all the other cells in our bodies. We're having our skin, our hair, our bones, our muscles. Constantly, some of these cells are dying, and new ones are being generated to replace them. But this doesn't happen with a woman's eggs. Once eggs die, they can't be replaced. That is unique to the woman's eggs. It also happens in the cells of our heart, and also the cells of our neurosystem, our brain, our nerves. Those are the only cells that are never renewed once they're damaged. And that's why, for example, if someone has a stroke or if someone has a nerve that is damaged, you can never get back that full function again. You can break a bone and that will heal and you can get the function. But if it's something like your nerve, like the nerves or your heart, once there's damaged tissue there, it can never be renewed. And this attrition of eggs continues from when a woman is born, and when she's at puberty, she has approximately 500,000 eggs, and the average age of puberty is between 11 and 13. And from puberty, that's when a woman starts to ovulate and release eggs. And on average, women release just 1 egg a month, but they've started off with 500,000 eggs. However, when a woman releases 1 egg, it's not just that 1 egg that is released. There are about anywhere between 100 to 1,000 eggs that start that journey. And that journey takes about 2 to 3 months, similar to the duration it takes for a man's sperm to form. But in the end, before ovulation, just one of those eggs becomes the dominant egg and is released, and the other 100 or 1,000 eggs die out, and then a new set of eggs start to grow. And that's why a woman on average has between 500 to 600 periods during her lifetime before she goes into the menopause, when she has no more eggs left. And this is just a diagram showing the ovary. And I was talking about the many eggs that a woman had when she was in her mother's womb. They're called the primary follicles, and those develop into antral follicles until they're finally, one is ovulated and the rest just die off. And if you've ever had a pelvic scan, this is an image of an ovary, and those are the developing follicles. And that big black one, that is the dominant follicle that the woman releases. And once she releases this egg, the other follicles that have been accompanying that egg die off to be replaced by another cohort. So what affects a woman's ovarian reserve, the number of eggs she has? And this is really down to genetics. There are just some women who lose about 100 eggs a month, and because of that, they're going through their overall original number of eggs slower than other women who, for some other genetic reasons, lose about 1,000 eggs a month, and are therefore going through their supply much faster than those who are only losing about 100. And for those women who lose about 100 eggs a month, their supply lasts longer, and they will generally go into a late menopause at the age of about 55 to 60. The average age of the menopause is about 52 to 53 here in Ireland. If you're losing about 1,000 eggs a month, you're going to use up your supply much faster. And for those women, they may even have the onset of the early menopause, and some of them will go into the change of a small number between the ages of 30 and 40. Okay, and there's no reason why this happened. This is just something that was genetically predetermined, and it's just like your height. Some women are short, some women are tall. There's nothing wrong with a woman having a low ovarian reserve or a high ovarian reserve. That's just how Mother Nature has made us. It's called our normal distribution of humans, of animals. And this is a normal distribution curve. And you can use this to determine our weights as people, our heights. There's some people who are very tall up on this end. There's some people who are very short on this end. And there's some people who are average. Most people are average, but there's some people who have a much larger ovarian reserve, and there are those people who have a low ovarian reserve. Okay, I always use the example of Michael Jordan, who's a basketball player, and he's 6'5". He's tall. He's on this end of the average height of a man. Whereas Lionel Messi, who is a great football player, is about 5'5", and he's short in terms of average height of men. But both of these people are outstanding sporting individuals. There's nothing abnormal with Lionel Messi being 5'6". Sorry, there's nothing abnormal about it. He's that, but he's a great football player. And just like Michael Jordan, he's a great basketball player, and he's 6'5". They just have different heights, but they're good at what they do. Same thing with women's eggs. There are women who have low ovarian reserve, but their eggs are good quality, and others who have high ovarian and their eggs are good quality as well. This is just a normal distribution of one of our characteristics as humans, one of which is ovarian reserve. But what is egg quality? Now that is something completely different. And egg quality is determined by women's age. And that is, the older a woman becomes, her egg quality will decrease. And the reason for this is really down to the eggs are getting older. The age of a woman's egg is the same as almost as her natural age. If a woman is 42 years old, her eggs are 42 years old. If a woman is 25 years old, her eggs are 25-year-old. And the younger the eggs are, the better quality they are, because the DNA is younger and it's more well preserved compared to as the woman gets older. Okay? And and people ask me, is there anything they can do to improve the quality of their eggs? And I always say, there is nothing, there is no drug, no diet, no supplement that I know of that can improve a woman's egg quality. However, I do know of many things that can negatively affect the quality of a woman's eggs. And those factors are mainly external environmental, and they include smoking. Smoking has a very, very bad effect on quality of women's eggs. It has free radicals, which can affect the DNA inside a woman's egg and decrease the quality much quicker than just the natural aging process. Caffeine, raised BMI, poor diet, eating lots of processed foods, fatty things can affect the quality. Lifestyle, a sedentary lifestyle without exercise or a healthy diet. All of these things can negatively affect the quality of women's eggs. There are other things which could be occupational, such as if you're working in a nuclear power plant or in a place which has lots of X-rays, and you're exposed without proper protection. Those can affect your quality, but those are rare. For most, the average person doesn't work in a nuclear power station or work with X-rays without having any form of lead protection. And why does age affect egg quality? Okay. Now, reproduction in humans involves the transfer of genetic material from the parents to their child. And this is done in the form of genes carried on chromosomes. And chromosomes are what allow the transfer of this genetic material from the mother or the father to the child. Most of us humans are chromosomally normal in that we have 46 chromosomes. For a man, he'll have 46 XY. For a woman, she'll have 46 XX. The reason why a man is, everything is identical apart from the XX and the XY in a man and a woman. And when an embryo is being formed, for it to be a healthy embryo, which will be capable of giving of resulting in a live, healthy birth, it needs to get 23 chromosomes from the male partner and 23 chromosomes from the female partner to result in a normal 46 chromosome embryo. If it's 46XX, it results in a girl. If it's 46XY, it results in a boy. Women always to provide a healthy child will always have 23X provided from their eggs, whereas the man can have either 23X or 23Y, and that determines the sex of the child. But with men, because their sperm is very young, in 2 to 3 months in relativity, it is almost consistent that a normal looking sperm will either provide 23X, which is the normal complement for a girl, or 23Y, which is the normal complement for a boy. But for a woman's eggs, even by at the age of let's say 35, only about 50% of them may have the normal complement of 23X. And as she becomes older, that complement decreases, so that by the age of 40, it's only 20% of the eggs a woman has that complement of 23X. The rest will have they would have either lost one chromosome or even gained some chromosome, and therefore it is an uneven number that is fertilized by the male sperm. And the women's complement may be 21X, which is the 21 chromosomes, or 22X, 24X, or even it's missing the X chromosome, 21-0, in such, and that can result in a condition called Turner's syndrome, which is a girl who is born without functioning ovaries. And if an abnormal egg is inseminated by a normal sperm, the results are one of the 5 I've listed down below. Either A, no fertilization takes place, which is the majority of the time. Most chromosomally abnormal eggs do not get fertilized. Or B, there is abnormal development, and even that embryo stops developing maybe on day 2 or day 3 after fertilization, because even it picks up that it doesn't have the correct genetic material to continue. Or 3, when that embryo becomes a blastocyst, a day 5 embryo, it can't implant into the uterus to start to grow. Or if it does implant, most of the time it results in a miscarriage, and a woman gets pregnant, but unfortunately has a miscarriage. And that's the body's way of dealing with an embryo which would not survive up to term or even be shortly after term. And lastly, there is one of the not options, but one of the alternatives, which is an chromosomally abnormal fetus can implant and it can grow, but later on during the pregnancy, it's picked up that this embryo is not developing as most normal embryos will, and you can pick up conditions such as Down syndrome, which has an extra chromosome 21 and has a 47 complement, or Turner syndrome, which is 45XO, which is missing a chromosome. And this is literally a distribution of how many normal eggs, or let's say good quality eggs, that a woman will have, because good quality just literally means the normal complement of chromosomes. At birth, a woman has literally 100% of her eggs are chromosomally normal. By the time she hits puberty, they're literally about 90% of her eggs are chromosomally normal. By the time she's in her 20s to 30s, that is down to 70 to 80% of her eggs are chromosomally normal. And at that time, the risk of a woman becoming pregnant and having a child with Down syndrome is about 1 in 5,000. By the time a woman is 30 to 35 years old, that risk, the amount of chromosomally normal eggs is about 50 to 60%. And between the ages of 35 to 37, it's about 40%. And at that time, the risk of, if a woman becomes pregnant, the risk is, if there are 350 women who became pregnant, one of them would have a child with Down syndrome. And as you go, and as the age gets higher, so does the percentage of chromosomally normal eggs. And between the ages of 37 to 40, it's down to 20 to 30%. By the time a woman is between the ages of 40 to 42, it's 10 to 20%. And at that point, if 100 women became pregnant, one of them would have a child with Down syndrome. And if you get to the age of 42 to 45, that's down to 3 to 10% of the eggs are normal. And the risk of Downs at that age is about 1 in 20. And that's why, as you see, as a woman is advancing in age, whatever the quantity of eggs she has, it is the proportion of eggs that are chromosomally normal is constantly decreasing. So it doesn't matter what quantity she has, what quantity and in terms of number, that percentage is almost consistent with her age. such that by the time she's over 45 to 47, it's less than, I'd say, 1 to 3% of the eggs that are chromosomally normal. And so, hence the confusion when people talk about low ovarian reserve. They tend to think that people with low ovarian reserve have poor quality egg, which is not correct. Most women, as they get older, the ovarian reserve goes down. Most, but they are, as I've already mentioned, they are women who go through premature menopause, whereby they are much younger and they have low number of eggs. Okay, and sometimes doctors say because they're young and have a low number of eggs, those eggs are chromosomally are not good quality, which is not true. Okay, it's just those women have less eggs, but the percentage of eggs that are normal remains the same. And this is where it comes in. If a woman is 35 years old and she has a good ovarian reserve and we collect 10 eggs from her, statistically speaking, 5 of those eggs will be chromosomally normal. If a 35-year-old woman has 4 eggs collected, we know, and she has low ovarian reserve, it is not that those eggs are abnormal, but it's just 2 out of those 4 eggs are normal. It is exactly the same, that's 50%, and it's exactly the same as a woman who have collected 10 eggs or 20 eggs. If she had 20 eggs, that would have been 10 of them are chromosomally normal. The statistical chance is the same. Whereas if a woman is 42 years old and we collect 10 eggs from her, we know that 10% of her eggs, and therefore one of these eggs should be normal. However, if that woman is 42, we only collect 4 eggs. What is 10% of 4 eggs? It's 0.4. And this is where it becomes more difficult because you can't have 0.4 of a normal egg. The egg will either be normal or abnormal. And so statistically, for a woman who's 42, you need to collect at least 10 eggs from her if she has a low ovarian reserve in order to have 1 chromosomally normal egg. And that's just statistically. And that's why sometimes women who are older, it takes most, with a low ovarian reserve, it takes more cycles to collect a good number of eggs to give you a statistically good chance of getting that 1 chromosomally normal embryo. There are many ways of measuring ovarian reserve, and as I said, for quality it's based on age, but for reserve there are many ways of doing it. There are some that are crude, and there are some that are more accurate. One of the easiest way of trying to guess a woman's ovarian reserve is her age. Most women who are under the age of 40 will have a good ovarian reserve. Not all of them, but most of them will. Okay. 2 is just asking a lot of you on here, if you ask your mother what age she went into the menopause, if your mother tells you she went into the menopause when she was over 50, that's a good indicator of when you too will go into the menopause. Okay, because most of the time this runs genetically within the female line. If your mother tells you she went into the menopause when she was in her late 30s, early 40s, that is an indicator that you need to do something very quickly because you are most likely going to follow that same pathway. There are some more accurate blood markers or scan markers, such as one of the easiest and cheapest is a blood test called the FSH, which is normally done between day 2 and day 4. And generally, if your FSH level is less than 10, it's an indication that you have a good, as in you've got lots of eggs. It doesn't talk about the quality, it's just talk about how many you have. There's another test, which is an ultrasound scan, and we count the number of antral follicles, immature follicles inside a woman's ovary, and anything over a total of 8 shows a good ovarian reserve. And lastly, there's a blood test, which I'd say is the most accurate and most consistent blood test, is an AMH blood test. And generally, if you get an AMH over 8, it means that you have a good ovarian reserve. The higher that number is, the more eggs you're able to get. And and as I said, lots of clinicians talk about low ovarian reserve, but really there is something called the Bologna criteria, and this is really a technical term for doctors when defining what they call a woman with low ovarian reserve. And it's as long as it has a woman has at least two of the following factors, do we then criteria, do we then classify her as a low ovarian reserve? And one is she over the age of 40? Two, has she had a previous low response to IVF whereby less than 3 eggs were collected? And does she have an antral follicle count of less than 5 to 7 or an AMH of 3.5 to 8? Or less than 3.5 to 8 picomole. This is what is scientifically is called a low ovarian reserve. Because if you're a 30-year-old woman and you have 60% of your eggs are good and you have a low AMH of 3, and we're able to collect only 2 or 3 eggs, 1 or 2 of them are going to be chromosomally normal because of your age. But that's a very different story to someone over the age of 40, where only 20%, roughly 20% of the eggs are normal. And if we collect 1 or 2 or 3, the chances are high that none of them are going to be normal. But this is something that is set by age, not by the number of eggs you have. I spoke about AFC, and this is a pelvic ultrasound scan showing 3 different scans. This is a woman with a very, very good ovarian reserve. You can see all these follicles. She has 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 follicles just in one ovary. And I'm sure there'll be more if we go through different planes. Whereas this is more or less average. This woman has 1, 2, 3, 4, 5, 6 follicles. That's about average. And then this is a woman with a low ovarian reserve with perhaps just 1 follicle there, okay? And this is a woman with a very low ovarian reserve based on her antral follicle count, which can be determined by an ultrasound scan. And again, this is just a diagram. It looks a bit busy, but it's just literally a diagram showing that as women get older, the AMH goes down with age. This is a natural progression of things as a woman. And it's not talking about the quality, because the quality is determined by the age. And this is a distribution. There are some women who are 26 who have a low ovarian reserve, others who have a high ovarian. This woman will have more eggs than this lady. It doesn't mean anything different, because to make a baby, it takes 1 egg. Collecting 20 eggs from this lady is not going to, I don't know of any woman who's going to try and get pregnant with 20 eggs all at the same time. Yes, she can get lots of eggs in one cycle, but if she just wants 1 child, it's just going to take 1 egg and 1 sperm. This lady, you can get maybe 3 or 4 eggs. All she needs is 1 egg and 1 sperm in order to make a baby. And that's where the AMH comes in. It's just telling us how many eggs we can collect, not the quality. And so some people would ask, how do we get good eggs? And firstly, you can't improve and as I've already mentioned, you can't improve the quality of the eggs you have. But there are things that can be done, that we can do and you can do yourself, which will lower the quality of those eggs. The first one is lifestyle: smoking, caffeine, alcohol, lack of exercise, unhealthy diet, having a BMI over 20. These are things that can be worked on and changed. You can stop smoking, cut down on the caffeine, cut down on the alcohol, increase your exercise. And then when it comes to us as the clinicians, it is the protocol we use, because this is really the nitty-gritty of it. How we stimulate a woman during her IVF cycle will determine whether we maintain the quality of the eggs she has, or we negatively affect that. And in my personal experience, when you're using high doses of stimulation for women with low ovarian reserve, small number of eggs, can negatively affect the quality of those eggs. Using higher doses does not mean getting better quality eggs. It can actually have quite the opposite effect. The best quality eggs come from purely natural cycles. Women have, as human beings, we have been multiplying for millennia, and this is because we have evolved to release 1 or 2 eggs each cycle, and that egg to become fertilized in a non-lab environment, which is the woman's womb and fallopian tubes, and we've continued to being able to reproduce for millennia, as I've already mentioned. And that is with very low amounts of FSH. FSH is the primary drug that we use in IVF to stimulate eggs. But what I've found is, if you're going to do IVF, mild doses, mild stimulation gets you good quality eggs. And less sometimes, and when I say less, I'm talking about the dose, can sometimes mean more. Okay? And that is one of my, that less sometimes means more quality. And generally, when I talk about a mild stimulation, it's using doses between 112 to 225 units. And by the way, I should emphasize, this is not a SIMS policy. I'm talking about my personal policy as a clinician in how I approach managing of my patients. And this is normally best achieved in antagonist, the short protocol. Okay, and there are other reasons why the agonist or long protocol is not very good for women with a low ovarian reserve, because it makes it even more difficult. But ideally, you want a mild stimulation in a short protocol, and that is normally the second best thing to nature itself. IVF is about a balance in stimulating, to trying to get a good number of eggs that normally nature would provide, in order not to without affecting the quality of the eggs collected too much. Because if we were to try and collect one egg each month, which is the best, it would take a long time to get like 10 eggs, and also be much more expensive. And so we're trying to find that fine balance of trying to get a good number of eggs in 1 or 2 cycles without affecting the quality of the eggs too much. And then, but then there are some women who even stimulation is not suitable, whereby natural cycle IVF is more suitable, where we use no drugs at all whatsoever. And this is really more suitable for women with a very low AMH of less than 0.7 and irregular periods. These women are sometimes even perimenopausal. And the thing to do is not even to try, because even trying to stimulate these women you would end up with even getting no eggs at all when you start to, because that just has a negative effect on the ovary. What strategies can be done? If you know that if a woman is approaching 35 or over, and she's not actively trying to get to start a family at that point, what I'd advise is that she freezes eggs, because the older you're going to become, the quality of your eggs is going to go down. So if you know that you have low ovarian reserve and you're almost 35, consider fertility. Even less if your AMH is really low by the time you're 30, consider preserving your eggs by doing egg freezing, because there's nothing that can really be done to stop the natural aging process. But one thing I have to emphasize as well is that egg freezing is an insurance policy. It is not something that is definitely going to be used. We do know that 70% of women who freeze eggs do not use them, because most of them conceive naturally when they enter a relationship. They are not infertile. They have a low ovarian reserve, but their egg quality is good. And most of them will conceive naturally when they enter a relationship. This is a busy chart, and it's just showing the number of roughly the number of eggs required in order to get a good chance of having a child. And these are for the different ages, and it shows that if you're 30 to 34 years old, you'd have and you collected about 12 eggs, you have about a 60% chance of having a child, of having one child from those eggs collected. Whereas if you're 37 and you collected 12 eggs, it's again still about 60%. Whereas if you are 38 to 34 and you collected 12 eggs, you only have about a 40% chance. And if you're 41 to 42 and you collected 12 eggs, you only have about 25% chance of having a child from the 12 eggs collected. So it's just showing the number of eggs you need to collect to have a good chance of having a live birth. And this was from a study that was done, I think, back in 2016. So the aim of IVF for women, the aim of IVF is always, it's for quality, not quantity. Because for a healthy baby, as I've already emphasized, you need one healthy sperm, a healthy egg, and a healthy uterus. That has never changed for millennium. It has always been the same. You need just one healthy sperm, one healthy egg. Sorry, it was a typo there when I put eggs instead of egg, to achieve a healthy uterus to result in a live birth. So what is my advice for women with a low ovarian reserve? If you're going to go through natural IVF, my advice, my approach is using mild stimulation, using low dose FSH in a short protocol, as opposed to conventional high dose long protocol IVF. Natural IVF if your ovarian reserve is low, and if you're trying to get pregnant, it's to do, and you have a very low ovarian reserve, it's to consider doing multiple cycles, maybe 2 or 3, 2 or 3 cycles back to back, in order to batch and collect a number of embryos before you start transferring, or even considering something for women, especially over the age of 40, considering something called pre-implantation genetic screening to find out which embryos are chromosomally normal before replacing them. And that's something that is also offered at SIMS. Customize your treatment. I always advise that discuss discuss with your doctor. Give them your ideas. Doctors don't like myself. We don't know everything. Sometimes we want to take on ideas. Tell us about what your experience has been, if you've had any previous treatment, what you have read and what you think may be good for you, and have an open discussion with your doctor, because it's our job as your doctors and your fertility team to give you the support and help you in making the decisions that are important to you, in treating you and finding the right protocol or treatment plan that suits you, because not everyone fits into the same box. What the correct treatment for one of your friends is not exactly the same treatment for yourself. Get involved and ask the questions. What protocol are you choosing? Why are you choosing this protocol for me? What is my ovarian reserve? How is this going to affect? How many cycles do you think is realistic that I'm going to need to get a good number of eggs in order to achieve that pregnancy that I want to achieve? I think that was my last slide, and thank you all. This is just a small slide I have at the end of a baby who I find very cute. But thank you all, and sorry for going on for so long. And I don't know how I'm going to get all the questions answered, but I've been given a number of questions by one of the people on the panel, and I'll attempt to try and answer them. Does reducing your BMI before egg collection affect the quality of eggs, or is the quality already affected by having a BMI? I would say having a raised BMI can affect the quality of your eggs. Losing weight to a healthy weight has a number of benefits. The first one will be, it will stop, if your high BMI has been affecting the quality of the eggs, losing weight will at least stop that, loss being as steep as it is, and it becomes going back to your normal. So yes, losing weight it doesn't reverse, it doesn't stop, but it will make sure that the decline is not as steep as it was before. So that's the first thing. The second thing is that it makes your surgery easier for the surgeons who are treating you and safer. And B, it also improves with the implantation of the embryo. And 3, decreases the chances of miscarriage for yourself. And number 5, when you're going through your pregnancy, it decreases the risk of complications such as having gestational diabetes, such as having a deep vein thrombosis, which is blood clots in your calves going away to your lungs, and such as having instrumental or cesarean sections in pregnancy. So there are many, apart from decreasing the rate of the loss of quality, there are other very big benefits of losing weight prior to getting pregnant. At the point of egg, another question that has come in is, at the point of egg retrieval, is it possible to see the chromosomes in the egg and determine if they're chromosomally normal? No, not at the point of egg retrieval. The point where we can tell whether an embryo is chromosomally, whether that egg was chromosome, is when we have fertilized it with a sperm and we've grown that embryo for 5 days in the lab. And by that point, when an egg starts up as a single cell, and when it's fertilized by a sperm, it divides into 2 cells. And then on day 1, it's divided into 2 cells. Day 2, it's divided into 4. On average, on day 3, it's about 8 cells. And then day 4, it goes into this rapid division, and such that by the time it comes to day 5, it forms what is called a blastocyst that has about 200 to 400 cells. And there's a bit that forms the fetus, the baby. It's called the inner cell mass. And then there's the outer part, which we call the trophectoderm, and that goes on to form the placenta. And we can take 3 or 4 to 6 cells from the trophectoderm, what goes on to become the placenta, and we can send that off for analysis, and that will tell us whether the embryo is chromosomally normal or not. But that can only be done on day 5 of the after fertilization of the egg. It can't be done on the day when we collect the eggs. But once that's done on day 5, you normally get the results back within 7 to 14 days, so that you'd have an answer before your next cycle begins after the egg collection. How many normal eggs? The third question I have is, how many normal eggs would you aim to have collected to have in reserve, i.e. to preserve fertility? And as I've said, and I'll go back to this chart over here. I don't know if you've got it in the size, but normally what we normally recommend is in order to give yourself, and that really works for all ages, in order to give yourself a good chance of having a child, if you're between 30 to 34, collecting about 12 eggs gives you a 60% chance of having a live birth. And that's roughly the same as even if you're 35 to 37, about 12 is about 60% chance of having a child, one child. The chances of having 2 children from, if you've collected 12 eggs as a 34-year-old, is about 20%. So if you collect 12 eggs as a 30 to 34-year-old and 35 to 30, you have a 20% chance you'll be able to get 2 children. If you're 38 to 40, you collect 12 eggs, again, you have a 40% chance of having 1 child. And if you're 41 to 42 and you collect 12 eggs, you have a roughly 25% chance of having 1 child. So most doctors always recommend collecting 12 eggs if you're egg freezing to give you a good chance of course, the chances are better the younger you are, but roughly 12 eggs gives you a good chance of having a single child from that batch of eggs collected. I don't know if there are any more questions. I hope that I've managed to keep this talk within the given time. Aoife is online. If there are any other questions that have come through, I'm more than happy to answer them. I see there's some more questions in the Q&A. Aoife, am I allowed to read them? And
yeah, I think some of them you've covered already. So it's just some of those, and some of them are actually quite specific to that person's situation, and you would probably need to spend probably a little bit more time with them to understand the situation in full. So I would say that if you guys do have, if you want, you can send those questions to us offline and we'll do our best to answer them offline. Yeah, sorry, go ahead.
I was just going to say, I can do a rapid answer of some of these questions, and I'll just give a general answer. Okay. There's one question saying, my AMH level is 0.3 after chemotherapy, treated and ended 2 years. Is it possible to conceive? Yes, it is. But it also depends on how old you are. I've treated women with an AMH of 0.1, and they've managed to get pregnant after collecting 1 egg. And that was because that patient was about 26 years old. And although we collected 1 egg, because she was 26, the quality of that egg was very good, and she conceived straight away. And we did natural, we did not do any treatment at all. So yes, it is possible, but we need to have a bit more specifics about your aim, about yourself, rather than just your AMH. AMH is one thing, it just tells us the quantity. It does not tell us the quality of your eggs, okay? Another question is, if I got tested between 31 years and 40 years, the range between 1 and 10, and mine is 4.5, is that low or average for my age? I'm 32. I'd say 4.5 is low for a woman who is 32 years old. It is quite low. And if I was you, if you're in a relationship, I'd advise you to start trying to get pregnant quick. If not, I'd really seriously consider egg freezing, because as I said, 8 is what is considered low. 4.5 is quite low for a woman who's 32 years old. How can we achieve a good ovarian response in those patients with what stimulation strategies? As I said, for low ovarian reserve, it's mild stimulation. It is about being patient, maybe doing 1 or 2 or 3 cycles in order to batch up and collect a good number of eggs. What is the treatment for low sperm motility? That's a completely different different talk. There are many strategies. It depends on how bad the motility is. There are medical interventions, or there's even ICSI where we inject eggs, the eggs directly with the sperm in order to achieve normal fertilization. Does the trigger selection matter? For example, overtrill, double overtrill, gonasi. In my regards, yes, but that has nothing to do with ovarian reserve. I favor the double, using 2 overtrills in order to get good fertilization. But that doesn't matter whether you have low ovarian reserve or high ovarian reserve. What matters is the kind of trigger that is used, that you're using the right kind of trigger. How can low dose human growth hormone for weeks in advance? I have not seen any good evidence to show that growth hormone does improve egg quality. There's nothing, as far as from my talk, and I've already mentioned, I do not know of any strategy that improves ovarian reserve. And definitely I can say I have not personally ever used human growth hormone, and I don't know of any good evidence that shows that it improves the quality or the number of eggs collected. Can PGS affect the embryo and damage it? But yes, PGS can cause damage. However, that risk is extremely low, and I'd say less than 3% of embryos are affected by doing PGS. It's the benefit of doing PGS greatly outweighs the risk. Okay, depending on your age, you can have 50% of your eggs chromosome embryos abnormal, whereas there's only a small risk of 3%. So of damage, and so the benefit of PGS greatly outweighs the risk of embryo death. And most of the time, the embryos that are damaged are the ones that were chromosomally abnormal anyway. Last question is: I am 36 with a low AMH of 6.5. Do I have 6 months time to lose weight before IVF, or should I start now? 36 years old with an AMH of 6.5. Yes. You'd have, if you're going to lose weight, if you're going to use those 6 months productively in order to lose weight, then yes, I don't think your AMH would drop dramatically over from 6.5. I'd imagine that by the time you've lost, with 6 months time, your AMH would still be about 6.5, 6 to 6.5. So it shouldn't really affect the number of eggs collected. I hope that has been, sorry for the quick fire answers, but I thought I'd just quickly answer some. You've been all very, very nice to log in. I thought I'd just try and answer some of your questions very quickly.
Thank you so much, Dr. Moses. No, appreciate that. And you've really given such a good overview on this topic, and definitely just keep an eye out for other topics like this. We have recorded this as well, so you will have it available on our YouTube and website channels. And keep an eye out for other talks in the near future. And if you have any other further questions, you can send them into the communications@sims.ie. It should pop up with a reminder tomorrow. But thanks for attending tonight. Thank you, Dr. Moses. And yeah, I hope you all have a lovely evening. Thank you.
Thank
Bye.
you.
Bye.
Bye-bye.